So welcome everyone to the Caring Together, Innovation and Interdependence in Ageing support webinar. I would like to begin by acknowledging the traditional custodians of the lands on which we each join today and pay my respects to elders past and present. I am joining you from the beautiful lands of the Bundjalung Nation, and I extend that respect to all Aboriginal and Torres Strait Islander people participating in this webinar. My name is Christina Agar, and I'm a Professor of Nursing at Southern Cross University and the KLE Academy of Higher Education and Research in Belagavi, India. And I also hold a conjoint research appointment with Northern New South Wales Local Health District. On behalf of GANA, the Gerontological Alliance of Nurses Australia, it's a pleasure to welcome you to this hybrid event delivered in partnership with the Australian Association of Gerontology, the University of Sunshine Coast, La Trobe University and the Deakin University. GANA is a community of trusted specialist nurses and assistants who value working with older people and their families and carers in all care settings. I think the QR code on the first slide there is a link to the GANA website. We know that family carers are vital yet often under-recognised. They're part of our healthcare system. I'm currently leading an NHMRC funded project that partners with family carers to prevent and manage delirium. And through this work, we see firsthand the essential emotional, physical, and the logistical support that carers provide. Their contributions enhance continuity of care, they improve outcomes, and they do help reduce strain on health systems. It's therefore my great pleasure to welcome our esteemed panel of presenters. Professor Patrick Kor will discuss supporting family carers of people living with dementia from a Hong Kong perspective. Associate Professor Ken Ho from La Trobe University and Dr. Jackie Chan from Higher Colleges of Technology in the United Arab Emirates will jointly discuss empowering carers of people with a diagnosis of dementia. Dr. Eva Yuen from Monash University and Deakin University will provide insights into how social connection and health literacy can shape carer outcomes. And finally, Daphne, Dr. Daphne Cheung from Alfred Health and Deakin University will present the importance of embedding didactic models in dementia care and practice. Just quickly before we begin, and I think Matt did touch on this, just a few housekeeping items. Please submit questions and comments via the QA box. Don't use the chat for questions as these will be collated and then they'll be directed to the speakers during the discussion period. If you experience any technical issues, Matt, the AAG administrator, will assist you via the chat box. And today's session is being recorded and you will receive an email in the coming days with access to the recording and any other available presentation slides. But thank you again for joining us. I hope you enjoy this important and very timely discussion.
Thank you. Thank you. So good morning, everyone. Thanks, Professor Christina Agar, for your introductions. I'm Daphne Cheung from Deakin University. I will be the facilitator at the Deakin campus today, together with Associate Professor Mia and also JC Hyland at the Sleepy Down venue. I will also be the presenter of today as well. So a warm welcome to all of you joining us at the campus as well as online. So we are very delighted and also privileged to have these opportunities to share the ideas about carrying the dyads. On behalf of all speakers, we would like to express our sincere gratitude to the Australian Association of Gerontology and the Gerontological Alliance of Nurses Australia for collaborating these events. And also thanks to Professor Victoria Trailer for initiating this, Vanessa for organizations, and also the IT team for the support, especially Matthew. So we are truly privileged. So we we will have a very wonderful program today. We have altogether 5 speakers. So in order to advocating for the interdependence between older adults and their care partners. So we will have to hear from 5 speakers. So the first speakers will be Associate Professor Patrick Kor. He will share the innovations and insights in supporting family caregivers. So Professor Patrick Kor is from Hong Kong. His research interest is lies on supporting the carers of people living with dementia, mindfulness, and gerontology. And he received numerous awards for his outstanding teaching and also research, as well as empowering nurses and students to provide better gerontological cares. So please join me in welcoming Professor Kor to present supporting family carers of people living with dementia, innovations and insights for better care in Hong Kong.
Okay, thank you for your kind introduction, Daphne. So can you hear me clearly?
Yes.
Okay, good morning, everyone. Thank you for joining me today. I'm Professor Patrick Kor from the School of Nursing at the Hong Kong Polytechnic University. Today, I will be sharing our research and also insight on supporting family caregivers of people with dementias with a focus on innovative approach and also practical solution. So dementia is a rapidly growing global health challenge. According to the World Alzheimer's Report, there are currently 46.8 million people living with dementia worldwide. And this number is expected to nearly triple, reaching 131.5 million by 2050. And about half of these individuals with dementias are living in Asia. And Hong Kong, the situation is equally pressing. The numbers of people aged over 70 living with dementias is projected to rise from 100,000 in 2009 to over 33,000 by 2039. Importantly, 80% of the people with dementias in Hong Kong are living in the community, not in the nursing home. That means the majority of care is provided by their family caregivers, placing a significant burden on them. So let's look at the age distribution and also the dementia prevalence in Hong Kong. You can see the risk of dementias increase sharply with age. Nearly half of the citizens in Hong Kong aged 85 or both are living with dementias. So dementia is now the 7th leading cause of death in Hong Kong. And this statistic highlight that the urgent needs for effective caregivers and also the people with dementias in Hong Kong. So here is some brief introductions about dementias. Dementias is a cognitive and also clinical symptoms of progressive cognitive decline, which impair people's function. Several common symptoms, including the memory loss, disorientations, impaired visual spatial skill. But more important is the behavioral and also psychological symptoms such as delusion, hallucination, wandering. Many family caregivers tell us that this kind of BPSD is the major burden and also stressors to them in the daily living activities. So many family caregivers in Hong Kong experience a high level of stress and also burden. And actually, there are several interventions and also supportive services for the people with, for the family caregivers of the people with dementias in Hong Kong. And you can see the table here. There are some common psychosocial intervention and also supportive service for the family caregivers, including the cognitive training and stimulation or cognitive stimulation therapy, which aims to promote the cognitive functions and also quality of life in the people with dementias. Some respite care service, the caregiver skill training, and also support group. There are also, this kind of services is very common in the elderly care center and also the community center for the people with, for the family caregivers of the people with dementias. At the same time, you can also see some limitations on different kind of services. For example, the cognitive training or cognitive stimulation therapy for the people with dementias. The positive effect may be found on the people with dementias, but not carry over to the family caregivers. Some respite services, they may provide the spaces for the family caregivers to take a break. However, several studies found that the stress reduction is transient, may not be able to manage the chronic stress in the family caregivers. And the caregiver skill training it is very important in the caregiving journey, but some study also found that caregiving skill is only part of the stressor in the family caregivers. More than that is some family conflict, loss of freedom, and also difficulty at work. It cannot be solved by the skill training. Some support group, peer support group, several study also found that the results for stress reduction is inconsistent. That's why we come up with a new approach, which is the use of mindfulness in Hong Kong to reduce the stress in the family caregivers. So what is mindfulness? Mindfulness aims to increase the individual attentions and also self-awareness at the present moments non-judgmentally. And according to several literatures, mindfulness has been found to be effective at improving several psychological symptoms, including anxiety, depressions, cognitive functions, psychotic symptoms, and also stress reductions in different populations, not limited to the family caregivers. And during the mindfulness training, it includes different mindfulness practice, such as the sitting meditations, body scanning, mindful eating, and also mindful walking. The aims of these mindfulness trainings is to help us to pay our attentions at the present moment and then disengage with the negative thinking patterns, and finally accept and also observe the thoughts without judgment. And you can imagine most of our attentions may not pay at the present moment. For example, if we did something wrong in the last few weeks, we may keep thinking why this happened, or we are worrying something that may happen in the next few weeks. So most of our time may not be paying at the present moment. And mindfulness is a skill to help us to pay our attentions at the present moment and observe our thoughts without any judgment. As mentioned, mindfulness is widely used in different populations for stress reductions. And several years ago, we conducted a systematic review to look at the use of mindfulness in the dementia family caregivers. And in this systematic review, we found the preliminary effect on the stress reduction and also the improvement in the depressive symptom in the family caregivers. But at the same time, we also saw several limitations in the intervention for lethality control and also the unclear long-term effect in the family caregivers. And most important is about the dosage and also the protocol of the mindfulness interventions, because the traditional mindfulness program, for example, the mindfulness-based stress reduction program, it lasts for 8 weeks, and each week the attendants have to attend 2.5-hour sections weekly. So this demanding dosage may be quite challenging for the family caregivers because they are heavily engaged with different family caregiving tasks. So in this review, we found that the attrition rate in the previous mindfulness program is quite high in the family caregivers. It is about 17.2% in the attrition rate. That's why we try to modify the mindfulness program in 2019. And then we conduct a small pilot study on 36 family caregivers in Hong Kong. And in this pilot study, we found that after we modify the program and shorten the durations and also change the face-to-face sections to the telephone follow-up, we found that the feasibility improved and also the attrition rate also improved. And many family caregivers report that they can practice the mindfulness about 180 minutes every week. And in this pilot study, we also found that the effects, positive effects, can be found on the stress, depressive symptom burden, and also the quality of life in the family caregivers. And in the focus group interview, some family caregivers also told us that some potential effects can be found in the people with dementias, including their behavioral symptoms. We further interviewed the family caregiver asking why the people with dementias will have some potential effect on their behavioral problem, because the family caregivers told us that after learning mindfulness, they learn how to react to some of the questions and also the behaviors of the people with dementias. They will talk to the people with dementias kindly, even they ask the question repeatedly. So this potential effect is also quite encouraging. That's why we later conduct a full randomized control trial to look at the effects of the mindfulness interventions. And after the pilot study, we also work out a conceptual framework and try to understand more about why the mindfulness interventions can help the family caregivers. So this mindful coping model originally proposed by Gallen and his colleague in 2011. It integrated the principle of mindfulness theory and also the stress coping framework. It explains how mindfulness practice can transform the ways the family caregivers respond to stress, particularly in some challenging situations. So you can see this framework is begin with the recognition that stress arises not just from the external events, but from how we are placed or interpret those events through the primary appraisal and also the secondary appraisal. So for the family caregivers, daily challenges such as managing the behavioral symptoms or coping with some uncertainty can be perceived with some threat. So after learning the mindfulness, it can help the family caregivers to cultivate a non-judgmental awareness at the present moments. That means the family caregivers can learn to notice their thoughts, emotion, and also body sensations without any immediate reaction or labeling them as good or not at that moment immediately. And through the mindfulness practice, the family caregivers can develop the ability to decenter. So what is the meaning of decenter? That means they can step back and also observe their experience from a broader perspective. This decentering allows the family caregivers for cognitive reappraisals. So with this increase of the awareness and also the ability to reappraisal, the family caregivers are more likely to engage in adaptive coping strategies. This might include problem solving, seeking support, or simply accepting the situations that cannot be changed, rather than resorting to avoidance or ruminations in their caregiving journey. So over time, this practice leads to reductions lead to the reduced emotional distress and also greater resilience and also improve their psychological well-being. So based on this conceptual framework, we conduct a larger randomized control trial in Hong Kong. So in this randomized control trial, we recruit the family caregivers in the community through the community center. So totally, we recruit about 113 family caregivers in the community in this randomized control trial. And in the randomized control trial, we further add the process evaluation to identify the strengths, limitations, and also the difficulties of the interventions. So here is the hypothesis about our randomized control trial. We hypothesize that the people with the family caregivers in the intervention group will have better improvement than the control group immediately after the interventions and also at the follow-up after 6 months of the interventions. In the randomized control trial, we measure different outcomes, including the perceived stress and also different secondary outcomes such as the depressions, anxiety, resilience, burden, and also the health-related quality of life. At the same time, we also measure the outcome on the people with dementias. As you still remember in the focus group in the pilot study, some family caregivers reported the improvement in the BPSD in the care recipient. That's why in this randomized control trial, we also measures the outcome on the people with dementias. So in this study, we recruit the family caregivers aged 18 or above with a blood or by marriage relationship. So most likely the caregivers are taking care of the spouse or the parent-in-laws with dementias. In the inclusion criteria, the family caregivers have to provide most of the daily activities and also support for the people with dementias with the daily contact for at least 4 hours per week. And they're able to speak Cantonese to understand all the teaching materials. And we exclude those family caregivers. They are currently learning mindfulness and also with some acute psychiatric illness. So here is the design of our intervention program. You can see our mindfulness program lasts for 10 weeks. From week 1 to week 10. And the mindfulness program included face-to-face mode and also some telephone support in between the second and also the third month. In the 5th and also 7th and 9th month, we only provide the telephone support for the family caregivers. But in the rest of sections, they need to attend our 2-hour sessions weekly in the 1st, 2nd, and also the 3rd month. So here is some of the example of the mindfulness protocol. Each sessions, they will have a main theme. For example, in the first sessions, they will have the theme about the awareness and also the autopilot mode. And we also have different content and also homework for the family caregivers. Here is some of the photos on the face-to-face sections. They are practicing the body scan and also the sitting meditations, mindful walking. And the group discussion is about their mindfulness practice between different family caregivers. And this in this randomized control trial, we also have the control group. We provide them with some brief health educations in order to balance the group effects. So here is the outcome. Here is the outcome. As mentioned, we measured most of the outcome through the questionnaire, including stress, anxiety, depression, burden, resilience, quality of life. And in this study, we also have the process indicator, which is the level of mindfulness. We measure the level of mindfulness through the FFMQ questionnaire in the intervention group. And we also ask the family caregivers to use a logbook to record their self-practice mindfulness weekly at home. So in this study, we randomized the 113 family caregivers into the mindfulness group and also the control group, and look at the outcome at immediately after the interventions and also at the 6-month follow-up. So you can see the demographic here. Majority of the family caregivers in our studies are female, and most of them taking care the people with taking care their parents with dementias, followed by spouse. And here is some of the results about the attendance and also adherence in our randomized control trial. So as mentioned, the attendance and adherence is one of the challenges for the family caregivers because they are engaged with the family caregiving task. And we can see that in our modified mindfulness program, the attendance rate is quite high. It is 84%, and attrition rate is only about 9.7% in our interventions. And most of them can practice about 180 minutes mindfulness at home. And for the outcome, you can see the stress level here. The orange color indicate the control group, and the blue color indicate the mindfulness group. You can see the intervention group has significant decrease in the stress level, and also at not only at the T1 and also at the time point T2. However, in the control group, even they have some stress reduction at T1. However, the stress level bounce back at T2. And for the depressive symptom, we also found a positive effect in the intervention group, but no effect in the control group. And also, we also found the positive effect in the anxiety level. However, there's no effect on the burden in the family caregiver. And there are several secondary outcomes, such as the quality of life, including the physical quality of life and also the mental health related quality of life. We found a significantly improved in their mental health quality of life. And for the BPSD, we found the family caregivers have improvement in the distress related to the BPSD of the people with dementias. However, when we look at the actual BPSD in the people with dementias, we did not find any significant improvement. And for the resilience, there is no significant improvement in the intervention group and also the control group. And for the process indicator, we use the FFMQ to measure their level of mindfulness. We found after learning the mindfulness, the level of mindfulness significantly improved at T1 and also the T2. And this is also correlated with the improvement in their stress reduction and also improvement of the psychological well-being. After the interventions, we also conduct the focus group to ask the feedbacks from the family caregivers, and there are several themes generated from the focus group, including the positive impact from the family caregivers. The impact can be found on their emotion, cognitive skills, and also physical health. And some positive impacts is on the family caregiving, such as the dyadic relationship, and also some mood and also behavioral problem of the people with dementias. And we also ask about their success in adopting the mindfulness practice and they also tell us if they want most of the important thing is how they incorporate the mindfulness practice in the daily life and also facilitate the learning in the mindfulness. And they also report some difficulty in adopting the mindfulness practice, such as the personal factor, including the time constraints, cannot focus, and some environmental factors, such as the disturbance by the people with dementias or other family caregivers. And they also provide some suggestions for the modifications in our mindfulness program. So based on our randomized control trial, we find several limitations. For example, the accessibility. Some of the family caregivers found that the face-to-face mindfulness program is hard to access, and some possible solution may be use some more flexible ways, such as the hybrid or online mode for the intervention delivery. Some in our study, we mostly use the self-reported questionnaire to measure their stress reductions. And however, nowadays we have different wearable devices to measure our stress level. So in the coming future, we'll mostly will use some other objective measures, such as the heart rate variability, to measure some of other physiological markers on their stress. And lastly, we find several missing data on the self-record of mindfulness practice from the family caregivers. So some solution may be use of the technology for checking the mindfulness practice pattern, for example, using some apps or website. So based on some limitations, we further conduct recently we've just finished another mindfulness study using the hybrid mode to deliver the interventions, and the findings is published in the journal of the Gerontologist, and you can refer to the journal for more details. So in this study, we are actually using the same design, the randomized control trial design. However, in this study, we try to use a hybrid mode. That means in the week 1 and week 2, we use the face-to-face mode to deliver the mindfulness interventions. However, for week 3 to week 5, all of the actually the mindfulness content has been recorded in video, and most of the learning materials have been transformed to digital format. So the family caregivers can learn the mindfulness on the website, and also follow the video to practice the mindfulness in the week 3 and week 5. And week 6, we ask back the family caregivers to come back to do some sharing and also talk about the difficulty and challenges in the mindfulness learning. So this is the design. In this randomized control trial, we recruit 139 family caregivers and randomized to the mindfulness program and also the control group. And here is the results. In this online mode of mindfulness program, we also find a significant improvement in their stress, depressive symptom, and also increase in their mindfulness level. However, we did not find any significant effect on the caregiving burden, dyadic relationship, positive aspects of caregiving, and also the BPSD in the people with dementias. And in this online mindfulness program, we also use the monitor the heart rate variability to check any psychological changes in their stress level. And through the HRV data, we also found that the family caregiver has a significant improvement in the RMSSD, which is an indicator for the parasympathetic activities, which means they have increased relaxation response in the mindfulness program. And many people ask me any differences between the online program and also the face-to-face program, but actually we did not decide we did not have a very rigorous research design to measure the differences between the online program and also the face-to-face program. However, I try to make a table to compare the results between these two studies. In the 2025 publication, we used the online mode, and the previous one we used the face-to-face mode. in the outcome of stress and also depressive symptoms, both of the study found a significant improvement in these two outcomes on the family caregivers. But some of the outcome, for example, the BPST-related distress, is only found in the face-to-face program. We do not find any significant improvement in the online program. And for the family caregiving burden, both study cannot find a significant improvement. However, for the feasibility, we found that the completion rate is much better in the online program, and the completion rate is much lower in the face-to-face program. So here is just a very quick summary between the results of the program. So, however, in these two studies, we found that actually, no matter it is a face-to-face or hybrid mode of mindfulness intervention, both intervention can show significant effects on the psychological well-being. And we also find that this sustainable improvement in the trials of mindfulness is quite positive because which indicate the participant can continue to engage in the mindfulness practice even after the program ends. And that's why we think that the mindfulness program is very suitable for the family caregivers of the people with dementias to support the long-term caregiving journey, because everyone know that the trajectory of dementia is quite long. Usually takes for 8 to 10 years. So we think that this mindfulness program is a very suitable approach for supporting the family caregivers of the people with dementias. So finally, I would like to end my presentation with the quote: "We cannot change the diagnosis of dementias, but through policy, innovations, and empathy, we can change the experience of living with people with dementias." So that's all about my sharing. Thank you very much.
So thanks, Patrick, for your sharing. I would like to introduce the speaker of our second presentation. Associate Professor Ken Ho is an associate professor in the School of Nursing and Midwifery and an accomplished nursing researcher with extensive experience leading both local and international studies. His research spans gerontology, particularly aged care and loneliness, migrant well-being, and qualitative methodology. He completed his PhD at the Hong Kong Polytechnic University in 2017, where he received the Faculty Distinguished Thesis Award. He also received the Distinguished Educator in Gerontological Nursing by the National Harvard Centers of Gerontological Nursing Excellence in 2022. He is also a Senior Fellow of the Higher Education Academy and published over 53 high-impact articles and currently serving as the Deputy Editor of Nursing Open under Wiley. Another speaker, Dr. Jackie Chen, is a nursing educator and researcher with extensive experience in stimulation-based education, gerontology, and health promotion. She is currently a lecturer in the Division of Nursing at the Higher College of Technology in the UAE and has previously held academic role at the University of Wollongong in the UAE. She has pioneered community-based stimulation training programs to facilitate families caring for older people with dementia. Her ongoing contribution to research, educational innovation, and international collaboration continues to advance global nursing practice. So without further ado, I will now hand the time over to Professor Ho and also Jackie.
Thank you very much, Daphne. Thank you very much for GANA and AAG for inviting me to have a presentation here to share our works, most likely working with my research team with Dr. Jackie Cheung. And those research are surrounding the caregiving of older adults living with dementia as well. So myself, most likely conduct quite a lot of qualitative research. So the first part of our research will be talking about the importance or our insight on the importance of engagement and active participation, which is informed by our qualitative interviews with carers of people living with dementia. And informed by this insight, and then Dr. Jackie Cheung will talk about her interventional studies and her reviews on what are the best strategies or what are the possible strategies that we can employ to strengthen the engagement and active participation of carers as well. So because at the beginning, we have already acknowledged the country, so I will skip the acknowledgement of the country. Okay, first of all, the story starts from quite a long time ago. I'm quite sure all of you will remember the COVID pandemic. And by that time, the whole world is facing a very severe problems, that is social isolation, particularly in the setting of aged care. So by that time, we know nothing about what is happening in the aged care setting. And that's why, working with a group of people coming internationally, we jointly produced a grant theory study, which involved the country of UK, US, Japan, Switzerland, and Hong Kong, China as well. So this international grant theory tried to focus on understanding what was the experience of family caregivers who has peoples or who has their loved one living in the residential care homes and living with dementia as well. So there were 3 research questions that we developed. The first one is how do family caregivers experience the public health measures or policies, such as visitation restriction implemented in the LTC during the pandemic long-term care settings, or how do these public health measures or policy impact family caregivers' relationship with their loved ones living with dementia and the engagement and care received by family? And what is the family caregivers' experience of interacting with LTC's staff and management? The importance of this study was about person-centered care and talking about family nursing, because when we talk about people living with dementia, another important aspect that we sometimes miss out is about the well-being of the family caregivers. And taking the family cares or taking the family as a whole unit, the well-beings of family caregivers as well as people living with dementias, all of their well-being are interdependent and influencing each other. So that's why these kinds of social restrictions, from our perspective, have a very great impact on the family well-being as well. So we conduct a grant theory based on Cheung's constructive perspective, and the participants obviously involve US, UK, Switzerland, Hong Kong, China, as well as Japan as well. So the number of participants in each country range from 2 to 5, and depends on the availabilities and the policy of social restriction by that time. And in return, we totally recruit 16 family members of individual living with dementia living in the LTCs. And you can see that around half of them are spouse of the people living with dementias, and the other half is about their children or significant others, very close others with less than 10%. And aligned with international trend, we know that most of the caregivers are women as well. And the data collections was employed with the interviews, and which is a semi-structured interview. And most likely there were 15 semi-structured interviews conducted, whether it is in individual or dyadic interviews. And the average time we spent for each interviews were 77 minutes. Because of the social restrictions, most of the interviews were conducted online or on phone. Meanwhile, there are still some cases we were able to conduct the interview face to face. The data analysis, we make use of the traditional grant theory analysis involving the open coding, focus coding, and memo writing as well. More importantly, because we know that there may be a significant cultural difference across different countries. And so we particularly have a comparative analysis within countries as well as across countries to identify what are the universal phenomena across the group. So I would like to give you an overview of the findings first. The findings, the major or the overarching theme of the finding is about negotiating for access to maintain relational continuity between the family caregivers and the people living with dementia in the LTCs. There are several areas that we are quite concerned about. First of all is that the first theme is about feeling excluded, isolated, and upset by the family caregivers. And the second point is about facing the personalizing situations by the caregivers, as well as that how do they navigate the challenging interactions throughout their interactions with LTC staff or the policy as well, and how do they live with the situation, particularly the post-pandemic situation. So I would like to give you some information about their experience, which is informed by their code. For example, feeling excluded and isolated and upset. Family caregivers, there are codes about it. A lot of people in these facilities, this is their last stop. And it is their home, and I feel like the care facility is cutting them off from everything, the way they did it. So this is a very extreme case, but it is a case happening around the globe that most of the LTC are cutting off all the connections, whether it is physical or emotional connections, cutting away the connections between residents and their family caregivers. So family caregivers are feeling stressed and concerned about their well-being of the people living with dementia. However, at the same time, they feel very disempowered because they feel there is an inability to see and be aware of how their loved one was doing physically and emotionally. So this is one of the areas that we are highly concerned. And in case if there are, unfortunately, if there is another pandemic, how do we prevent it to happen again? And the second theme we can see is about the facing depersonalizing situations. From my perspective, it is a very important one because it is not talking about the quantity of the relationship or the frequency of the contact between the caregivers of the residents. It is about the quality of the connections. Family caregivers, they face depersonalizing. They feel that they are degraded. They are degraded in the relationships that are most likely they are the unique family caregivers, unique family members of their loved one. But during the policy, during the restrictions, we see that family caregivers, because of the policies and the operations of LTC settings, they are degraded to be just a visitor to their loved one. So this kind of degrade in the quality of the relationships is a warning sign for us that, in fact, from person-centeredness of person-centered care, being in a relationship is very important, and being in a relationship, or when we talk about social isolation or loneliness, it is very important to think about not just about how frequent or are there any physical connections between people, but more importantly is about what is the quality of that connections. And unfortunately, during the COVID-19 pandemic all over the world, based on our information informed by our participant, we know that the quality of relationships is perceived to be degraded as something else. And the third theme is about navigating challenges, interactions. It is particularly, take a code which is highly relevant to dementia caregiving for dementia. Why? Because people living with dementias, sometimes they have difficulties to communicate verbally or physically. So that's why it is very important for family caregivers to have physical contact, to have emotional connections with those people. However, when during the pandemic, we know that we employed a lot of technology trying to replace the human connections. Do they work from family caregivers? It doesn't. Because you can see from the code, there was a remote visit, but when we actually met remotely, he was just sleeping all the time. If there was someone there, they will say to him, look over there, you are connected with your wife. So you can see that, in fact, we just seeing each other just like right now. I don't know who is sitting behind the screen, but at the same time, older people or residents in the residential care homes, because of dementia, they even do not aware who is sitting behind the screen. And even for the family caregivers, they cannot get immediate or simultaneous response from the older adults as well. So there is a discrepancy of the desired connections and the actual connections that they get for each party. And the final theme, living with post-pandemic circumstances. I think this is the only positive aspects that I can see from the studies about how do the family caregivers transcend their negative experience into something positive or into something hopeful. For example, COVID-19 profoundly changed how I see people, including my wife and others. I feel that I can find happiness living with my wife who has dementia. So, but we cannot take it for granted that all the family caregivers are able to reflect on their experience and transcend the negative experience into positive one. So this is a very good case that we know that there are possibilities to transcend negative experience into positive one. But how do we make it happen? That's why we try to think about, in fact, throughout all the 4 themes, we know that the overarching phenomenon happening behind the 4 themes is that family caregivers, they are trying to maintain their relational continuity with the older adults living with dementia. So how do they negotiate for the access? We know that there are several universal barriers around the world. For example, lack of effective communications. We don't say there is no communications, but is online communication effective for the connections? We don't know. Felt isolated and marginalized. It is quite obvious from their experience, from their feelings, and providing inadequate physical and emotional care. I can say that physical and emotional care is not only for residents living with dementia. It is also for people's it is also for family caregivers. We are providing their necessary physical and emotional care that they get from their interactions with residents living with dementia. And finally, we highlight that there is a degrade of the quality of the relationship. So all these, you can see that it is against the person-centeredness that is advocated by McCormack. And one of the philosophical stands of McCormack about person-centeredness is about being in relationship, which is very important when we provide person-centered care, have a relationship. People have to be in a relationship, and this is an important human need universally. And so from these kinds of interpretation and insight, the research team eventually developed an important insight about the importance of how we as healthcare professionals can engage family caregivers more actively, and how to enable them to actively participate in the caregiving for people living with dementia. This is a very challenging task because we know that even not just talking about the context of residential care homes, in fact, around the world, family caregiving in the family is very demanding, time-consuming, and have a load. And so it is about the case that even the family caregivers would like to have been engaged in a relationship, would like to provide more, but based on the resource limitation, for example, time, manpower, how are we able to maximize their engagement and facilitate their active participation? So that's why the whole research team, including Dr. Jackie Cheung, conduct and other stories that she will provide to you. Thank you. Jackie, your turn. Thank you.
Right. Thank you, Ken. Good morning, everyone. I am Jackie. Ken's presentation illuminates the frustration of family caregivers during difficult time, and at the same time, it highlights the significance in effectively engaging them so that they can actively participate in the caregiving journey, even during difficult times such as COVID-19 pandemic. Meanwhile, we understand that majority of people living with dementia reside at home and are looked after by their family members. Very often, these family members encounter difficulties in engaging in in-person training or support due to various reasons such as restriction policy, busy caregiving schedule, and living remotely. Because of these issues, our research team conducted a research project aiming to remotely engage these caregivers of people living with dementia who lived at home and to enhance their active participation in a remote training program, a video conference-based psychoeducation. This program aimed to enhance caregiver self-efficacy, empowering the family care partners, caregivers in their caregiving journey. The project had 2 phases. The first phase was a scoping review, aiming to synthesize strategies in promoting active participation in this population. Then in the second phase, we evaluate the feasibility of this video conference-based psychoeducation that has been integrated with these strategies. Next. So in the first phase of this research project, we conduct a scoping review according to the JBI guideline, research the relevant articles that were published between 2011 to 2021. We include 29 interventional studies of psychoeducation program for the family caregivers of individuals living with dementia who reside at home. This interventional study involved 13 countries worldwide. Then we perform a content analysis to synthesize active participation strategies to enhance engagement in the training program for this population. Next, please. This is an overview of findings of the scoping review. We synthesize 6 active participation strategies addressing the learning experience of caregivers and the role of facilitators. The first strategy and the most important of all are providing program contents that would best suit the needs of caregiver to enhance their relevancy. Literature has demonstrated high attrition in training program when the contents did not address the specific caregiving needs. The second strategy is to provide various teaching and learning methods such as discussion, role play, assignment, and practice to ensure active learning. Third strategy is to further enhance active learning by providing experiential learning such as simulation to ensure learning through experience and reflection, which is a powerful tool to engage learners. To deliver an engaging experience, the role of facilitators should not be overlooked. Therefore, the fourth strategy suggests that healthcare professionals or paraprofessionals, such as healthy older adults, should have the relevant experience or training to becoming a facilitator, so that they are able to anticipate the needs of family caregivers, and provide relevant opinions. The fifth strategy suggests that facilitators should collaborate with caregivers through active listening, making adjustments, exchanging feedback in order to co-develop caregiving solutions together. Lastly, the facilitators may promote peer sharing and support by providing lots of encouragement, highlighting the significance of experience sharing, and inviting peer participants to provide feedback so that the caregivers can learn from each other. Meanwhile, we also identify 2 hindering factors when implementing these active participation strategies. First, the negative caregiver emotions such as sadness and frustration could be provoked during sharing of caregiving experience. Drawing on this negative emotion could jeopardize their engagement. Second, open discussion and sharing of own caregiving problems and negative emotions could be a challenge when discussing negative issue is a taboo in some cultures. In particular, this cultural challenge has been reported in Chinese culture from the literature. Next slide, please. With these synthesized strategies, we develop our program in a way that would promote caregiver active participation. This video conference-based psychoeducation consists of 6 weekly sessions, and each session lasts for 2 hours. To address the specific needs of the family caregivers, we determine the 6 weekly topics through literature review to enhance their relevancy. Then each weekly session employ various teaching and learning methods, including dyadic teaching via PowerPoint, discussion, and weekly assignment. To provide experiential learning, we employ simulated patients to portray as an individual living with dementia so that the family caregivers could interact and practice communication skill. And the picture here is our simulated patient. We have her consent to put her picture here. And thereafter, we had debriefing with the family caregivers to reflect on their performance and help generalize their learning into different contexts. As we anticipated, negative emotion could be provoked during the session, especially during sharing of own caregiving experience. Debriefing exercise was practiced together with the family caregivers at the end of each session to address any possible sadness and frustration. The program was delivered by myself, and my background is a registered nurse with training specialized in dementia caregiving. Throughout the program, I adopt active listening and tailor suggestion to family caregivers' background and resources. In addition, I encourage the family caregivers to share their feelings and similar experience in caregiving, inviting them to provide comments and suggestions to each other. To address the possible cultural challenges, I highlight confidentiality at the start of each session and invite those family caregivers who are more active and chatty to start with during discussion, so that they serve as role models for those who were more hesitated and reserved in experience sharing. Next slide, please. In the second phase of this project, we test the feasibility and preliminary effectiveness on caregiver self-advocacy of the program by using a quasi-experimental design. A process evaluation was also conducted using a qualitative descriptive design. We recruit 60 family caregivers of people living with dementia who reside at home in Hong Kong. 30 of them received a video conference-based psychoeducation, and the other half received the same psychoeducation program but delivered in person. Their satisfaction level, completion rate, and changes in caregiving self-advocacy were collected before and after the intervention. Among those who received video conference-based psychoeducation, 27 caregivers were interviewed individually to explore the experience to the program. Descriptive and inferential statistic methods were employed to analyze the quantitative data, while content analysis was used to analyze the qualitative data. Next slide, please. The findings demonstrate feasibility and acceptability of the program as reflected from the high completion rate and satisfaction level. We define completion as achieving 80% of attendance, and the completion rate was well above 90% in both groups. In addition, the average score of satisfaction were about 4 out of 5 in both groups. The family caregivers were particularly satisfied with the facilitator's opinion and experience shared by other family caregivers. They also appreciate how the program was delivered. Next slide, please. In addition, no significant difference was demonstrated in the caregiver self-advocacy score between the both groups, indicating that video conference psychoeducation is comparable to in-person psychoeducation on enhancing caregiving self-advocacy. Next slide. We interviewed 27 family caregivers in the intervention group as a process evaluation to explore the experience to the program. They appreciate the video conference format as handy and facilitate open discussion, likely because they feel that the home environments are familiar and make them feel comfortable to openly share their inner feelings. They also perceive knowledge gain and enhanced caregiving skill and reduce stress level. They also report worries over failure in simulation and not able to complete home assignment, which is understandable due to busy caregiving schedule, and it is suggested to be flexible on handling this issue to minimize that burden. What I want to highlight here is that they appreciate active participation during the program, wherein they were engaged, they could listen and observe to peers, they reflect on their own caregiving approaches, and interact with peers who have similar caregiving experience. Next slide, please. The caregiver were particularly engaged in simulation. They were immersed when enacting with the simulated patient, wherein the conversation was spontaneous as in real life situation. In addition, being able to listen and observe in the simulation, the caregiver anticipate their own response and emotion, and compare different ways of doing demonstrated by other caregivers. Moreover, the debriefing helped them reflect on their own solutions and facilitate generalization of learning in other similar situations. Lastly, the caregivers enjoy peer support from other participants. Some of them became friends. They also appreciate chatting and getting reassurance by the facilitators. Next slide, please. The research project highlights the remote support or training program that are integrated with active participation strategies may successfully engage the family caregivers. However, one of the biggest challenges is digital divide, including access to smartphones, tablets, and a broadband internet service. The other challenge is digital literacy of the family caregivers. In Hong Kong, we are very lucky. The utilization of smartphone and tablets in all age groups is about 90%, and the broadband internet access is readily available. Besides, the family caregivers in Hong Kong may have adapted to online training and support, as many of these training programs were delivered via video conference during COVID-19 pandemic. While in other parts of the world, the access of smartphone and broadband internet connection may not be as readily available, and the digital literacy among the family caregivers may be unknown. Therefore, we need to be cautious when translating the evidence into different contexts, particularly considering the digital divide and digital literacy. In addition, these research findings have limited generalizability as the sample size is small and limited to Chinese population. To conclude, Engagement and active participation of family care partners, caregivers are significant in training program and support so that we can effectively empower them in their caregiving journey. And these are the references. That's the end of the presentation. Thank you for your attention. Thank you.
Thank you, Ken and Jackie, for your insightful sharing. So we are coming to the next speaker, Dr. Eva Yuen. She is a Senior Research Fellow at the Center for Quality and Patient Safety Research at Deakin University in partnership with Monash Health. Her research focuses on person-centered communication, health literacy, and social support to improve outcomes of people affected by cancer, with a particular emphasis on informal carers and culturally and linguistically diverse communities. Dr. Yuen's work explores how social connection, communication, and health literacy shape caregiver well-being. Topics that directly inform her presentation beyond the diagnosis, how social connection and health literacy shape caregiver outcomes. She has published around 50 peer-reviewed articles and contributed to successful Category 1 grant funding. She also holds leadership roles across various committees, including the CARA's Special Interest Group of the Psycho-Oncology Cooperative Research Group. So let's welcome Dr. Yuen. Yeah.
Thanks very much, Daphne, AAG and GANA for inviting me to speak today and to share my work. I'd also like to acknowledge the Wurundjeri people who are the traditional custodians of the lands on which we meet today. As an overview, my presentation will explore how social support, social connection and health literacy impact health and well-being for caregivers. And briefly as background, my training was in the field of health psychology, and the work that I'm sharing today has been conducted with cancer caregivers. However, there is likely overlap with the challenges that are faced by caregivers of people with dementia. And I'm grateful for this opportunity to share this work with you and also to enhance my own work by learning about all the good work that's being conducted in dementia care. And we know that family members and friends play a critical role in providing vital care, as well as practical, physical, psychosocial and financial support for people with a chronic disease or disability. And providing care is stressful, demanding and burdensome, and this can result in poor psychological outcomes for caregivers. Burden is described as the perceived emotional, social, physical, financial or spiritual strain as a result of providing care. And burden has been associated with poor psychological outcomes, decreased work productivity and finances, as well as changes to social and family relationships for caregivers. And burden has also been known to impact a person's capacity to provide quality care. For example, increased burden has been associated with a preference for palliative care over life-sustaining treatment for people with cancer, and higher caregiver burden has also been associated with increased mortality and being hospitalised for older people who are receiving care. So what do these findings mean? The research shows that caregivers have increased needs for direct intervention and support. And to develop effective interventions, one way is to identify potentially modifiable factors that contribute to burden and psychological morbidity in caregivers. And this in turn has the potential to inform the development of targeted interventions and strategies to ultimately improve caregiver health and wellbeing, improve quality care, as well as to improve health outcomes for people who are receiving the care. I wanted to share with you a construct known as health literacy. And broadly, health literacy is described as a person's capacity to find, understand, use, and critically appraise health information and services to make optimal decisions about health. And notably, across various populations, in caregivers, inadequate health literacy has been linked to poorer outcomes for their care recipients, including poorer self-management behaviours in people with heart failure, greater frequency and duration of hospital admissions for geriatric patients, and also increased pressure injuries and mortality rates for people in palliative care. There aren't very many studies, however, which have looked at health literacy and its impact on caregivers' overall health and wellbeing. Alongside this, I'd like to turn your attention to the role of social support and connection for health and wellbeing. Briefly, social support is described as the quality and quantity of different types of instrumental, appraisal, emotional, or informational support. And in contrast, social connectedness is described as having the perceived, meaningful, close, and constructive interpersonal relationships with other people, groups, or society. And social connection is also characterized by a sense of belongingness, closeness, and intimacy with other people. Increased social connection has been associated with reduced risk of depression in older adults, as well as increased well-being and self-esteem. And social connection has been shown to be an important factor in promoting optimal psychological well-being. However, I just wanted to point out that the quality and quantity of social support doesn't always lead to social connection or closeness or belonging with other people. And so it's been argued that even when people have adequate social support and friendship networks, they can still report a lack of perceived social connection or a sense of belonging within their social environment. And so together we were interested in understanding how specific components of social interactions, as well as health literacy, improve caregiver psychological outcomes and well-being. And so very briefly, I'm just going to run through 3 studies that we have conducted. And so in this first study, bear with me a second, building on existing research, our early work aimed to explore caregiver characteristics that were associated with burden, social connectedness, and psychological outcomes in caregivers. And we also wanted to explore the strength of the relationship between burden and psychological symptoms and how this might be impacted or moderated by perceived social connectedness. And so you can see this is the moderation model that's shown in the figure. And we hypothesized that greater perceived connectedness would be associated with a smaller relationship between caregiver burden and psychological morbidity. Very briefly, we recruited caregivers from Prolific, a crowdsourcing research platform, and we included people who were aged 18 and over who provided care to someone with cancer in the past 5 years. And we collected survey data on burden, social connection, depression, and anxiety symptoms. We had 189 caregivers in our sample, and most of them were female. Over 40% were an adult providing care to their parent. And we explored which demographic and caregiver characteristics were associated with depression, anxiety, burden, and social connectedness. And looking at these associations, for age, older caregivers were more likely to report higher depression, while younger caregivers were more likely to report greater anxiety. For gender, women were more likely to report higher anxiety, and spousal caregivers compared to other caregiver groups reported higher caregiver burden, depression, as well as anxiety symptoms, and they also reported lower perceived social connection. And caregiver illness and disability were also associated with depression and anxiety. And looking at the moderation analysis, controlling for significant demographic and caregiver characteristics, we ran 2 moderation models, one with depression as the outcome and one with anxiety as the outcome. And so with depression as the outcome variable, we found that as perceived social connectedness increased, the relationship between caregiver burden and depression decreased. So that is, the effect of burden on depression symptoms was smaller when caregivers reported higher levels of perceived social connectedness. So you can see here with the blue line, people who reported low social connection they were more likely, the relationship between burden and depression was much higher, whereas for those who had the higher levels of social connection, the relationship between burden and depression was much lower in this group. However, with anxiety as the outcome variable, social connection didn't significantly moderate the association between burden and anxiety symptoms. So what do these findings mean? The finding that social connectedness moderated the relationship between burden and depression suggests that greater perceived connectedness provides increased psychological resources to manage the burden that's associated with caregiving, resulting in reduced depression symptoms. However, the finding that social connectedness doesn't moderate the relationship between burden and anxiety suggests that there are different mechanisms by which social support influences anxiety. And it's possible that social connectedness might not alleviate anxiety that's related to the uncertainty, fears, and worries that comes with providing care. And these might be better controlled through access to adequate information. And these findings are published in Current Oncology if you'd like to read more. And then looking to our second study, and leading on from our findings, we conducted a larger dyadic study where we aimed to explore how and whether social connectedness, social support, and caregiver health literacy would predict psychological outcomes in caregivers. And we also examined these associations accounting for care recipient characteristics. And caregivers and their care recipient as a dyad were recruited from 2 health services across Melbourne, Australia, and also through social media. And each participant completed a survey that included items on psychological symptoms, health literacy, social connection, and social support. Looking very briefly at the sample, we had 125 caregiver and care recipient dyads who took part in the study. And for people with cancer, over 70% of the sample were female, and the largest proportion were diagnosed with breast cancer. For caregivers, there were roughly equal numbers of men and women, and most were providing care for their spouse. And over half of the of caregivers reported having at least one illness or disability of their own. And looking at the results, we were interested in understanding which care recipient and caregiver factors contributed to caregiver psychological outcomes. And to do this, we ran a 2-block hierarchical regression model with care recipient factors in block 1, as you can see in the figure on the left. And we included both care recipient and caregiver factors in block 2. And in this first regression model, care recipient factors accounted for about 20% of the variance in the model, and notably only care recipient social support was a significant predictor of caregiver psychological outcomes. And in the full model, however, only caregiver factors, including caregiver age, caregiver illness and disability, health literacy and social connection were independent predictors of caregiver psychological morbidity. And in this final model, care recipient factors didn't contribute significantly to caregiver psychological outcomes at all. And you can see that caregiver social support did not significantly predict caregiver psychological outcomes. And while both health literacy and social connection influenced caregiver psychological morbidity, social connectedness was found to have the strongest influence. And also just to mention that in this final model, the factors accounted for over 61% of the variance in the model, suggesting that these factors were good predictors of caregiver psychological outcomes. And so turning to what the findings mean, the finding that only caregiver factors influenced caregiver psychological outcomes suggests the importance of enhancing caregiver skills and supports independent of the care recipient to ensure caregiver health and well-being. And the findings also add to the body of literature that suggests that social connectedness and support impact psychological outcomes in different ways. For example, for people who are struggling in different situations, they might report a lack of connectedness and a sense of social isolation, even when their social networks are available to them. And our findings underscore the importance of ensuring that caregivers understand the value of social connection and to make sure that they have strategies to promote and maintain connectedness when they're providing care. And because our findings show that this connection is a critical self-care activity. And our findings also highlight the importance of developing effective resources and strategies to make sure that caregivers have optimal health literacy to not only maintain the health and well-being of the person that they're caring for, but also to maintain their own psychological health and well-being. And if you wanted to learn more about this study, the findings have been published in Psycho-Oncology. And just very, very quickly, I wanted to share some of our work on how we've looked to address health literacy in caregivers. And caregivers have identified that health providers are their preferred and most trusted source for health information. But they've also reported significant challenges when communicating with providers, including lack of time, not wanting to burden providers, not knowing what to ask, as well as fear of being stigmatized for their lack of knowledge. An effective communication with providers has been shown to empower and prepare caregivers to provide optimal care. And at the time of our work, there were no evidence or skills-based training interventions that were available in Australia to support caregiver communication skills. And so I worked with colleagues in the US to adapt and pilot test a communication skills training program for caregivers designed to teach strategies for caregivers to communicate effectively with providers, to improve communication and to optimize their health literacy. The online module is brief. It's only 15 minutes long. And findings from the US have shown positive outcomes for caregivers of people with dementia, as well as those in cancer care, in improving communication knowledge as well as communication confidence. And I won't run through how we've adapted this program in an Australian context, but I just wanted to show you briefly our pilot findings. And so in a sample with 20 caregivers, pre-post study findings showed improved scores for depression symptoms, preparedness for caregiving, confidence in communicating with providers, as well as health literacy, suggesting that this module had positive impact on these outcomes in this small sample of caregivers. And semi-structured interviews conducted with participants also revealed that the module helped caregivers with improving their confidence to ask questions of providers, and they also felt empowered to be assertive and to persist until they got the information that they needed following this very brief education program. So to summarise this body of work, caregivers need support and resources in their own right to manage their own health and wellbeing. Excuse me, let me just turn to the next page. And future research could explore the effectiveness of strategies, interventions and resources to enhance skills to develop and maintain perceived social connectedness, and to help caregivers identify other people who understand their circumstances. And a recent study also showed the benefits of a positivity intervention program for increasing social connectedness in people with clinical depression and anxiety. And there's a potential to trial this type of program in caregiver populations. And future research has the potential to optimise health literacy through further testing and implementation of interventions such as the brief communication program, which has shown positive outcomes for dementia caregivers as well as cancer caregivers. And this will likely reduce caregiver burden and depression symptoms, has the potential to enhance care provision, as well as to optimise care recipient health outcomes. Thank you very much.
Thanks, Eva, for your sharing, and you extended our discussion from dementia, carers of dementia, as well as the individual living with dementia, to cancer carers. So I'm going to have a very quick sharing on this topic, strategic care for two, embedding dyadic models in dementia care and practice. So when we face a chronic condition in old age, especially like dementia, we may have some chronic conditions. So carers and people living with dementia or other chronic conditions actually are living in a shared ecosystem. They don't just live alongside each other, they living through each other's. So this is not a weakness, but it is a human connection, as what Professor Kor has shared. Understanding the interdependency changes everything. So we can't truly help one person without considering the other. So this figure showed the actor-partner interdependency model, which capture exactly this dynamic. It helps us to understand that we can't look at the persons with chronic condition or the carers in isolation. They are a dyad. They are a unit where everyone's experience can affecting the others. So I would like to quickly go through these studies have been conducted recently by my PhD students. This is a systematic review showing that in the past, we always want to know how focusing on carers or focusing on people with dementia and trying to improve their psychosocial well-being. But instead, these studies, we hope to see whether there's relationship between the psychosocial factors of the carers is related to the symptoms of people with dementias, as what Eva has done similarly, but we focus on the family with one living with dementia. we can identify that in our meta-analysis, we identified that the carer's distress actually has a moderate to large effect size affecting the depressive symptoms of people with dementia. These studies tell us that actually within the dynamic coping model, stress perceived by the partner is conveyed to the other verbally and non-verbally, and may also affecting the well-being of all the adults with dementia. So this is another study that our team has conducted. This is a very interesting one because in the past, we always focus on one partner instead of including them together. So this study, we involved the both party in a Q studies. We want them to identify what is the most important attributes that leading to a good dyadic relationship. So this is a Q methodology, and we have invited 40 couples to the Q sorting as well as the post-sorting interview. So we identified that mutual respect and cherishing the moment are the two most important attributes leading to good relationship. However, by means of by-person's factor analysis, we can identify that there are 3 types of participant, or we call it endorser, labeling what is the good relationship attributes. And we can see that in the factor 1, we identify around 20 participants, both consisting of the persons with MCI, the mild cognitive impairment, and their spouses. Seems that they are more tends to providing what they need in their family dynamics. So you can see that the commitment and dedication is the most important factors that contributing to the attributes. And there are some verbatims given by them. Like one of the quote is from the female spouse aged 79, the more you want, the more likely you will be disappointed. Thus, I do more than I would expect in return. That's contributing to their relationship. The second factor is the problem solver, consisting of 5 people living with cognitive impairment and their ex-spouses. So these endorse consists tell us that they are more focused on the problems rather than the importance of demonstrating so the acceptance and the commitment, etc., are the more important. They said, we are 2 individuals and we may have different thoughts. I cannot force my partner to be the same as I am, so I bear with it. So the third factor is partner. So you can see that in the dyadic relationship, not the so-called carers are the provider and the persons living with chronic condition is the care recipient. They are actually can be the partners. We always stick together and hold hands when we go out. Our neighbor always kidding us, saying that whenever they see me, they can also see my partner. This is from the person living with a mild cognitive impairment. So when we are looking into the care, we cannot just ignore the carers and regarding them as a provider only. They are in a relationship affecting each other. So there are some strategies to engage both in the care relationship. It is very challenging to include both parties because the program worker or carers or nurses may find it difficult to encounter both people in the group. So we conduct a systematic scoping review studies and identify some strategies. Most of the strategies are shared by Jackie before, but I would like to highlight that sometimes family caregivers and people living with dementia prefer group-based activities and intervention because they can also find some peer support. This is something very special for this population group. So as we conclude after the 4 different presentations, I want to leave you 4 essential insights that can transform how we approach dementia care and gerontological care. First, dyads are interdependent units not separate individuals. When we design intervention targeting dyads, we create synergy benefits that improve outcomes for both the persons with dementia and their carer. Second, dyadic bonds transcends physical distance. Carer could live miles away, can still provide meaningful support, challenging our traditional assumption that co-residence is necessary for effective caregiving. This means we must actively engage all carer in care planning, regardless of where they live. Third, technology may sometimes offer an exciting opportunity to support this relationship. However, there is no universal solution. We need to tailor our technological interventions to fit each dyad's unique needs and preferences. Finally, we cannot forget the carers need support too. And by embracing this dyadic perspective in our practice, we can shift our treating individuals in isolations to nurturing the interconnectedness and also their well-being in the entire care relationship. So I would like to open up the time right now to the Q&A sections. Because of the time, perhaps we can only accommodate maybe just a few questions. One question is from each side. May I invite Mia to, can you invite your attendee to share their thoughts, comments, or questions?
Daphne, there's no further questions from UniSC floor.
Okay.
I'll hand the mic to Vicky when you're ready.
Yeah, so I think some of the online discussion has been monitored and also replied to. But then we have some participants at the Deakin campus. May I invite whether you have any questions or comments you would like to discuss? No further? Okay, so I will pass the time back to you, Mia.
Good morning, everybody. My name's Victoria Traynor. I'm the co-president of GANA, as well as being Professor of Healthy Aging at University of Sunshine Coast. And I've got the extreme pleasure of doing the wrap-up. And I really don't know where to start with the thank yous. What an incredible symposium this was. The research that has been done is just really motivating and invigorating for, the field of dementia and gerontology. And I do feel like a grande dame of dementia care. I've been doing this since I was 17 years old, and to think that the research has come such a long way is just really inspiring. Each of the presenters is doing such important work. I would also like to thank Daphne for putting such a wonderful schedule together, Vanessa from Ghana, who has been the support person for Daphne, and of course AAG and Matt and his amazing level of patience as well as technical skills in making sure this all went smoothly. So we will be promoting recordings of each of these seminars on the GANA LinkedIn page, and it will go on to the GANA YouTube and also the UniSC YouTube channel. So I'm going to be recommending colleagues to take a look at this research. And for us here at UniSC, we're now part of the AAG's collaborating research centres. And I think today's seminar is just such an amazing example of a body of work that can be brought together across countries, across institutions, and across all the stakeholders that ensure that the quality of the life of people with dementia can continue to improve. So we'll all have to do a virtual vote of thanks and a clap for the whole team who put this together. And we'll see you next time. Thank you. And don't forget to join GANA. I think the link is in the chat for any of you who are not already members. Thanks, Daphne. So I'll leave it to anyone else who's got any other closing remarks.
Daphne, do you have anything to add?
Yeah, so I pass the time back to you, Matt. Yeah.
Okay, well, I think we're all done then. So thank you everyone for presenting from both of the live feed venues. A massive thanks to the technical support guy at Deakin, whose name I didn't catch, but without his help, we would not have got this show on the road. So big thanks to him, and thanks to everyone who attended online. We'll see you again for the next event. Thanks very much.
Thank you.
Bye.
Thank you. Bye-bye.
Bye.
Thank you.